Hello, thank you for being here. I'm Gina Vild. I'm the Associate Dean for Communications and External Relations for Harvard Medical School. So I'm delighted to have you here in the auditorium in Boston, and I want to welcome all of you who are watching us through the live stream from around the world. Can I ask of those who are here, how many are considering a future career in primary care? Okay, good. Well, we have experts who are going to talk to you about this and share what Harvard Medical School is doing currently and what we have planned for the future. I want to ask, though, at the end of the talks, we're going to take questions both from the audience and we'll pass around a microphone, and from the live stream. If you are watching on YouTube or Facebook, please write your comment in the question or comment in the comments section and indicate where you are from, where you are watching from, and we will try to get to as many of the questions as possible. So we're here today to talk about the revolution in primary care. We're going to discuss the transformations that are underway, those that hopefully will improve care for patients throughout the country and lead to better health outcomes for men, women, and children. Today, you're going to hear from the leader of our primary care center, which was formulated 9 years ago, and two of our primary care students, Megan Townsend and Mark Herzog. They're going to tell you about the work of the center and the experience of our students who are preparing for a career in primary care. So it's with great pleasure that I introduce Russell Phillips. Dr. Phillips is the director of the Center for Primary Care. He's the William Applebaum Professor of Medicine, Professor of Global Health and Social Medicine at Harvard Medical School, and a devoted primary care physician at Beth Israel Deaconess Medical Center. So please welcome our guest speakers. Thank you.
Thanks, Gina. Gina, thank you very much, and thanks for the opportunity to talk about primary care here at Harvard. I'll start by, can everybody hear me? Great, thank you. Well, it's great to see so many people here and so many friends of primary care here. What I'd like to do is talk a little bit about, as Gina said, about the primary care revolution. And we'll start by walking through the things that we'll talk about today. The first is, why do we need a revolution? The second is to define primary care, and I'll give her a definition of that, but I'd really like to define what it means personally for me as well. Then to talk about the context and the context in which the center has been created, the center story, its mission, and the vision of the center. Make some comments about the future of primary care, and then we'll really move to the highlight of our talk, which is to hear from the students as they talk about their views of primary care and their experience in primary care here at Harvard Medical School. We'll start with some disclosures. Both the students and I are committed primary care advocates, so you'll hear about that as we talk. I have another disclosure, a conflict of interest, in that I am an advisor to a company called Bicycle Health that cares for patients with opioid use disorder. It really has no bearing on today's talk. And the student presenters have no other disclosures. So why a revolution? The US clearly has the best healthcare system in the world, and there's no question that I would rather be getting healthcare than anywhere else. But as a system, we also have major challenges. We are by far the most expensive system in the world. We cost twice as much per person as the nearest country to us. And our outcomes are far worse than many of those comparison countries, with important population outcomes such as life expectancy and infant mortality ranking far down along the list of other countries. We face certain challenges in primary care. First, that payment for primary care visits actually undervalues the role that primary care needs to serve in a healthcare system. And our primary care teams are facing things such as challenging work life, high rates of burnout, workforce shortages that involve not only the primary care physicians, but all members of the healthcare team. And we face lower salaries and prestige compared to other specialties, which sometimes makes it difficult to attract primary care physicians and other team members to the work of primary care. So what is primary care? I told you that I would tell that in a more personal way. And for me, primary care was an opportunity to really develop relationships with patients. I care deeply about the value and believe deeply in the value of relationships. went to medical school wanting to develop relationships with patients and saw primary care as a way to do that. And in fact, over the course of my career, have developed relationships that now have been continuous over 20 to 30 years. I care for patients, have taken on their children sometimes, or their parents, so care for families, and I'm able to care for those patients within the context both of their family and their community. So one thing I do is provide continuity over time, which is one of the definitions of primary care. I also provide first access care, meaning that when a patient becomes ill, I'm the first person they see. That's an important role for me, in that it helps me to help patients navigate what can be an incredibly complex healthcare system. But it's also one of the things that makes primary care incredibly fun, because we see so many different things and patients bring in so many different problems that life is always different and always a challenge. So I look forward to practicing every single day. We also have an opportunity, I mentioned the fragmented healthcare system. I have an opportunity to help patients coordinate their care, to decide about when specialists are necessary, to help to choose specialists, and then help interpret the information that we get back from specialists. And then finally, another characteristic of primary care is the comprehensiveness that we provide. I can care for most of my patients' primary care needs within our practice. I'm very proud to be in a practice that has behavioral health integration, so we have social workers within our practice. We actually also can care for patients, for instance, with substance use disorder, right within our practice. The context of primary care is that it's incredibly important in terms of the value of our healthcare system. We define value in terms of quality over cost. Can we deliver high quality at low cost? As I mentioned, as a healthcare system, we don't do very well in that we're high cost and we're low quality overall. But if you look at the density of primary care physicians, and these next two slides will show that, as you increase the number of primary care physicians, you actually improve quality of care and you reduce costs. This slide, for instance, shows the number of general practitioners in a population per 10,000 people, and as that number rises, the quality of care actually improves. Quality is shown in the y-axis, where the ranking of 1 is the state with the best quality, the ranking of 51 is that with the worst, and you can see that as the density of primary care physicians, or as the number goes up, so does quality. On the other hand, there's a very different relationship between cost and density of primary care physicians. And again, in the x-axis, as the number of primary care physicians increases, costs actually go down. So we have this impact where we improve quality and we reduce costs. The center has done some original research that pertains to the issue of value in healthcare, and we've looked at population health outcomes. So for instance, another important part of value, or what we call the triple aim, is looking at population health markers. And one of those is life expectancy. I mentioned our life expectancy in the United States is not as good as in comparison countries. In primary care, many of us have the experience of saving lives, and the question is whether those lives saved actually translate into numbers that we can show on a graph or can demonstrate statistically. And so what we did is we did a fairly sophisticated analysis where we looked at the number of primary care physicians at the county level and asked the question, for counties that increased their number of primary care physicians over time, did that lead to an improvement in life expectancy? And for counties that lost primary care physicians, did life expectancy go down? And it turned out that, not to our surprise, but I think to some surprise of others, that in fact, as you increase the density, or as density increased to primary care physicians at the county level, life expectancy went up. And it went up by about 50 days, 51 days, which doesn't sound dramatic if you're thinking about a cancer treatment, but when you're thinking about a population health metric, it really is dramatic. It actually is about equal to the impact of cigarette smoking on life expectancy, although of course cigarette smoking worsens life expectancy, or obesity. So these are really important numbers. Another thing that we found in the same study that was published in JAMA Internal Medicine was also that the density of primary care physicians is actually going down. We looked between 2005 and 2015, and we lost primary care physicians during that period of time. That's continuing to go on, and we worry that's going to accelerate. You'll hear from Mark about his interest in rural health. That difference was most pronounced in rural areas. We also looked at the question about whether primary care investment saves money. As I mentioned, as you increase the number of primary care physicians, you can reduce costs. There's data from other countries that, in fact, as countries invest more in primary care, their total costs go down. So in European countries where they spend about twice as much or invest about twice as much than we do in primary care, their total costs are less. So a number of states in the United States now are experimenting with this by increasing what they call the primary care investment or primary care spend. And one of those is Rhode Island. And so what we did is we did a very careful analysis looking at the Rhode Island experience. Between 2010 and 2015, they actually increased their primary care spend. They doubled it from 5% to 10%. And we asked what happened to total medical spend. And it turned out that total medical spend actually went down relative to other states during that period of time. So the bottom line is that primary care investment actually does reduce costs, and primary care investment, in the sense that it produces more primary care doctors, more physicians, actually saves lives. So how do we get to do this research? Well, we got to do it because we work within the Center for Primary Care. And very briefly, to tell the story of the center, in 2008, students became very interested in how we might strengthen primary care at Harvard. The primary care was in crisis. It continues to be in crisis. Students knew that primary care drove value in healthcare, and they saw a gap in what this medical school was providing in terms of primary care training and experience to their students. So the students did community organizing. They created a petition, letter writing campaign, and it was a very effective campaign that led to the dean of Harvard Medical School at the time, Jeff Flyer, creating a task force, which I had the opportunity to co-lead, where we partnered with students and faculty and the community and came up with a strategy to strengthen primary care here at Harvard. That strategy was endorsed by the dean and was eventually funded by a very generous anonymous donor who created the center in 2010, as Gina mentioned. Our mission became one of fighting for primary care that improves lives around the world. And our vision is to revive primary care by sharing skills to help primary care teams, to lead by augmenting medical education with leadership training, to demonstrate by using research and lessons learned, and connect by offering insights on the creation of innovative care models. We worked in four different areas. One is research, another is education, a third is innovation entrepreneurship, and a fourth is systems transformation. And in these areas, in research, we're really trying to learn how we can do better to make primary care better. In education, we're training people to provide better primary care. In innovation and entrepreneurship, we're helping to stimulate the creation of startups that find new ways to deliver primary care in better ways. And in systems transformation, we're working with healthcare teams to improve the way they deliver care within their practices. Some very brief comments on the future of primary care. I mentioned payment, and I think payment is changing and will change. It's going to change to something that adequately will support primary care. Here in the center, we're advocating for increased primary care investment, both nationally but also at the state level. And we're also advocating for paying using VAT by value in a value-based way, as opposed to the current fee-for-service way. We think relationships will be fostered by teams and technology. I mentioned that relationships is one of the reasons I went into primary care. It's becoming increasingly difficult to maintain those relationships without using teams and technology. So I think we'll be doing that. And that's one of the things that our center is actually investing in doing research on. I think as our students might talk about, I believe the focus for physicians will be on high complexity patients. The question is, what's the role of primary care physicians and how do we distinguish those from other members of the healthcare team? And then finally, we'll be focusing increasingly on whole person care, integrating health behaviors and social needs. And I think the students will talk about this as well, about how we integrate things like behavioral health, oral health into primary care, and how we address social needs and social determinants of health. And an important area of work within the center is that's done by the students. Initially, we had a student advisory committee at their first meeting. They said, we don't want to advise the center, we want to lead the center. So it became the student leadership committee, and ever since they've done that. And they really are the student arm of the Center for Primary Care. They emerged from the student group that was instrumental in advocating for the creation of the center. And they really empower and train all health profession students, so they are interprofessional, to become leaders in primary care practice, education, research, advocacy, and community engagement. So I'm going to stop with my comments there and turn it to the students. Just to introduce them briefly, I think they were introduced as Megan Townsend and Mark Herzog. They're both dual degree students, and they both are getting both their MD and their MPP. So their MD at Harvard Medical School, their MPP at the Kennedy School. Megan is graduating this year, and Mark graduates next year. I'm going to lead with, the format for this is that we're going to have several questions that I'm going to address to the students. We'll give them each an opportunity to answer before there's an opportunity to have the audience ask questions. And the first question is really a general one, to tell a little bit about your story. And this first will go to Mark. And I wonder if you could tell us a little bit about who you are, where you're coming from, and the path that brought you to Harvard Medical School.
Grab that clicker. Thank you so much for the introduction, Rob. Grab the mic here. Well, for me, the story starts here in my home community in Central Appalachia and Southwest Virginia, and more specifically along Highway 23 and the hundreds of cars that travel that backcountry road each year headed to the Wise County Fairgrounds. Over the course of a 3-day weekend, close to 2,000 patients will arrive at the fairgrounds to receive free medical, dental, and vision care. And for many, it'll be the only care they receive all year. Patients arrive Thursday night to sleep out in their cars. And by Friday morning, the first patients will file through the fairground gates to receive care in converted livestock stalls, mobile trailers, and underneath tents. I know this story well, having witnessed community members, neighbors, and loved one driving down that backcountry road each year to go to that clinic. And I've witnessed as that scene has repeated itself for close to 20 years now, given a lack of a community-oriented health system and a lack of access to comprehensive primary care. As a health policy researcher and physician in training, I've returned to this clinic, and I've witnessed firsthand the consequences of limited access to comprehensive primary care. In particular, I remember caring for this woman who, over the course of 2 years, had bumped between free clinics out of concern for a growing mass in her neck. By the time I saw her, her thyroid mass had enlarged to the point where she had difficulty swallowing, and her imaging and labs were really concerning for a possible cancer. Her story, and the story of so many others at that clinic, fostered a commitment and a sense of urgency in my path to HMS, and a commitment to primary care in rural, vulnerable communities like the one that I came from. I came to HMS fully expecting that that commitment would bring me to a career as a primary care physician. But along the way, I lost sight of that original vision in my home community. I think between the ever-changing teams of residents and attendings and the ever-growing pressure to meet the needs and expectations of those teams, partnered with training in a large academic medical center where I was exposed to many different definitions of success in academic medicine. I got to the point that by the end of my 2 years, I needed to refine my original commitment to come to medical school. With the help of HMS mentors and advisors, I started a series of rotations that took me to rural Guatemala, the Navajo Nation, the Charlestown community here in Boston, and even back to my home community in Central Appalachia. And by the end, these experiences helped me to get back in touch with my original story to medicine. And I think I share that with you all because my own experience has made me recognize how hard it can be to hold on to that original commitment that brought you to medicine, whether you're here today as another medical student, a resident, physician, or staff member here at the medical school. It can be so hard to hold on to those original stories amidst the endless opportunities and resources that we have here at HMS. But I think now more than ever, we need an investment in primary care centered around community needs. Russ, you shared a little bit about the work that you and others at the center have led, demonstrating the importance of primary care access on population health outcomes. I think the more we hold true to our original commitments to medicine and our path here to HMS, the more we'll increasingly appreciate the importance of primary care. And I think there's a moment and an opportunity to use the resources that we have here at HMS to hold true to those commitments and address the needs of vulnerable communities, including rural communities here in the US, and to do so by delivering comprehensive access to primary care. And with that, I would love to invite Megan to share a little bit of her story and her own path here to HMS.
All right, thanks, Mark. So my own path to primary care also started on a long backcountry road, but as you can see from this picture, that road looked a little bit different than the one that Mark described. So this is a picture from a bike ride out to a rural clinic during my Peace Corps service in the West African nation of Guinea, which I've circled here on the map. After I graduated from Wellesley College in 2011, I served as a public health volunteer in Guinea for 25 months. When I was a volunteer in Guinea, I had the privilege of working alongside a lot of really amazing Guinean colleagues within their healthcare system, and I was quite inspired by their resilience in the face of a very under-resourced system and extreme poverty. I saw medical students huddled around computers, plugged into generators, gobbling up whatever medical textbook they could find online. I saw nurses walking miles into rural villages to distribute vaccinations, and even surgeons managing emergencies despite having very few resources at their disposal. Specifically as a volunteer, I was paired with a group of youth peer educators in the city of Bokeh, and I have a couple pictures of the educators here, and that's me and a few of the educators underneath a mosquito net during one of our projects. On the right side of the screen, you can see me pictured with my supervisor, a young man named Mr. Amara Omar Sila, who supervised me while I was working with them. The youth peer educators were incredibly smart and vibrant and kind, and they cared immensely about their community, and it was such a privilege to work with them. This is a few other pictures from our work together. When I came to medical school after the Peace Corps, I was most definitely looking to find a career where I could continue working in an underserved setting with an eye towards social justice and equity in healthcare. And obviously, I think for many of us, or even early in training, some of that optimism runs up against the hard truths of providing healthcare within our healthcare system here in the US. A patient relapses on substances and runs away from the hospital. A child has yet another asthma exacerbation because they live in an old building. A patient suffers a complication that could have been prevented if they could just afford their medication. All of these things can be really hard. I think part of this primary care revolution that we're talking about here today is how we can think about empowering our primary care teams to act on some of these ideals and this optimism that brings many of us to medicine, and in particular to primary care. I think one of the ways we do that is giving the teams more ways to directly impact the social determinants of health in their work. I think the Ghanaian peer educators that I talked about earlier were quite good at this, and I think that if we could find a way to empower some of our primary care teams to more directly act on social determinants, that would not only be that would be good for our patients, but that would also be good for our providers as we help everyone tap back into the reasons why we went into medicine. Up here, I put a few representative pictures from my path to primary care at Harvard and how I found out sort of where I belonged in the mix. So I have a picture up in the left corner from our trip that the Center for Primary Care helped us do to Navajo Nation last year. We went to learn about the work of community health workers in a rural area. Below that, I have a picture from the Museum of Fine Arts. This is a student leadership committee activity where we took students to the Museum of Fine Arts and we practiced looking at art to build our clinical observation skills. In the middle, I have a picture from the March from Our Lives in 2018. Last year, the Student Leadership Committee sponsored an op-ed contest where we encouraged medical providers to write about gun violence as a public health issue and to try that out. Part of my journey to primary care at Harvard was most definitely learning how to flex my advocacy muscles. So I also put a picture up here from an independent study I was able to complete with the United States Senate Committee on Health, Education, Labor, and Pensions. So all of these activities and many more were part of me figuring out where I belong within the broader medical community and me finding out where somebody like me who loves advocacy and community health and public service fits into the medical community in general. So I look forward to talking about more of these ideas in depth, and thank you for having me, Russ.
So thank you to both of you for sharing very personal stories. Yeah, thank you very much. And I know you both talked a little bit about this, but I wonder if you could expand a little bit on your primary care experiences here at Harvard. And I think, Megan, are you ready to keep going?
Yes. So I think definitely for me, the best part of my primary care experience at Harvard was the network of peers and faculty mentors that I was able to build along the way. That community was really important to keeping my passion for primary care strong through all the years that I was here. So right from the beginning of medical school, my very first mentor was Dr. Sierra Seelig, who adopted me to come learn about community health workers in a rural area. Later, Dr. Kathy Miller, who runs our Home for Family Medicine at Harvard, adopted me again and helped me figure out how I should apply for residency, how I should think about family medicine. And then this last year, the center and Russ served as my mentor for my thesis project, where we looked at primary care investment in Massachusetts. So the center has been there for me through all my years of medical school, and having that backup for me through all the years was really important. So that was definitely my favorite part.
Great, thank you.
Yeah, I would say that I'm very grateful for some of the clinical experiences I've had in primary care settings. During the course of my clinical training here at HMS, I've had the opportunity to spend a significant amount of time both at the Windsor Street Health Center in Cambridge and then also the Charlestown Community Health Center in Boston. And in both cases, I was really inspired by the stories of these health centers built both within and around the needs of vulnerable communities here in Boston. You know, both were built across the street from large public housing complexes. And speaking to today's theme of a primary care revolution, I really admired how the physicians there adapted a versatile training in primary care to meet the ever-changing needs of their community and their patients. You know, in particular, I had the opportunity to learn from the really innovative approach that the primary care physicians at Charlestown have taken to meeting the addiction needs of their patients. You know, they serve one of the communities most hard hit by today's opioid epidemic and have really responded to high rates of overdose deaths in their community by developing a comprehensive addiction treatment program.
Terrific, thank you. You've both served as co-leaders of the Student Leadership Committee. I mentioned the importance of that committee to the work of the center. What are you two most proud of from the work that your groups accomplished?
So I served as co-lead last year, and I think what I'm most proud of from that experience was most definitely the way that our committee was able to create a lot of different experiences for students to experience what primary care is like in a variety of settings. So some examples from that, we organized a trip to Western Massachusetts so we could expose students to what it's like to practice in a smaller town. And the physician we went and visited specialized in treating substance abuse disorders in primary care settings. So we wanted students to see what that was like also. We organized a trip to Navajo Nation. We learned about community health workers. We went to DC as a group to see a bunch of physicians working in federal health policy and to see what that was like. And I think creating all these experiences was important because in our regular clinical training, I think we do get exposed to a lot of different ways that you can practice inpatient medicine and subspecialty medicine, but sometimes we get this idea of we only have one idea of what primary care is, and we have some pretty strict ideas about what it is and isn't. But through these experiences, we're able to augment that for students and show that there is an incredible variety of ways to practice. Everything is different depending on what community you're practicing in, what kind of training you have, what you want to do in primary care. So I'm really proud that we were able to, through our activities with the center, provide all of these different opportunities for students.
At HMS, there are so many different opportunities, many of which are student-led, around advocacy for health equity. And at times, I think the tremendous number of opportunities can lead to separate silos among student groups. And this year, my co-leads and I really made a concerted effort to try to build a cohesive community across the HMS, HSDM student body around student advocacy projects. So for example, we coordinated with the Racial Justice Coalition this year around the time of the midterm elections to sponsor both an op-ed writing workshop and contest to really help elevate student voices in their home communities around the time of the midterm elections. And this year's winner, Sanjay Kishore, published a piece in the Richmond Times-Dispatch that really, I think, was a powerful piece calling attention for state and federal legislators from Virginia to help address the ongoing opioid epidemic with implementation of syringe exchange programs in the state. Other examples is a symposium that my co-leads and I organized on that was called Achieving Health Equity in an Unequal World. And we worked with students from not only the Longwood area with the medical school and the dental school, but students from the business school, from the Kennedy School, students from the Institute for Health Professionals over at MGH. And I think it was a really incredible testament to this sense of building a community when at our event we had both undergraduate students, we had medical trainee students, we had residents, we had clinical professors, we had community organizers, community nurses, and health professionals. And I think that really spoke to our effort this year to really build a cohesive community around health advocacy.
It's wonderful work that you do, and we are so thrilled that you do it within the center. It's really terrific. Thanks for sharing that. The next question is really about research and scholarship, and I know you both have been involved in scholarship, and I wonder whether you might talk a little bit about it and how you're using scholarship to help achieve healthcare transformation.
Well, I'm happy to speak to that because I'm now coming to a close with my year at the Kennedy School, where I've had the time and support to really think a lot about what sort of scholarship I want to be doing in my career. Before I came to HMS, I mentioned a little bit earlier some of the work that I had done in my home community. And the experiences there, witnessing physicians struggling to meet the needs of their communities in a resource-strained setting, really motivated me to come here to HMS to not only develop a clinical skill set, but also a policy skill set to really rethink the way that our rural health systems offer and deliver care. And during the year at the Kennedy School, I've really kept in mind one big question, which is how do we build rural health systems that are better aligned to community health priorities? And through mentorship at HMS and the Kennedy School, I've started to do some work with some folks in Pennsylvania around the Pennsylvania Rural Health Model. And also John is here as well, and he's contributing to this work. And here in that project, what they're trying to do and what we are hoping to support them in is paying rural hospitals across the state in a different way that not only keeps rural hospitals open and serving the needs of communities, but also realigning the type of care that they provide in the hospital to better align to community health priorities. And I think as we increasingly move away from our current ways of financing healthcare in the US, with so-called alternative payment models, there's going to be an increasing role for primary care physicians who have the capacity to not only treat illness, but really address some of the upstream needs that prevent that severe hospitalization in the first place.
So I also finished a year at the Kennedy School. I did my master's degree at the Kennedy School last year, and most of my academic work outside of clinic focused also on building my skills as an advocate and trying to figure out where I fit in that space. At the Kennedy School, most of my work there focused on the opioid epidemic and policy responses to that, and then health workforce issues as well. I think the capstone, though, of my academic work outside of clinic was definitely the thesis project that I completed as part of my medical school and my Kennedy School degree, and Russ served as my mentor on that thesis project. So we took a deep dive on this concept of primary care investment. So we know that in Massachusetts, about 7 cents of every healthcare dollar gets spent on primary care, and that's not enough to build the kind of really robust teams that we need to support good quality primary care. And so we did some thinking, and we heard about Rhode Island when Russ was speaking earlier. We did some thinking about some of the laws that have been passed in different states to encourage primary care investment, and we did interviews across the state with healthcare policy stakeholders to see where people were on this issue and what something, a primary care investment push might look like in Massachusetts. So I learned a lot in doing that work, and relating back to this concept of the primary care revolution. That work helped me think a lot deeper about how we finance healthcare, and it is my hope that as I go forward that I can participate in some of these conversations about alternative payment methods and changing the way that we put our financial incentives into primary care in a more intelligent way. So I really look forward to that.
Terrific, thank you both. One of the things that we thought a lot about as the center was starting was culture, and the culture at Harvard, and to what extent that culture supported primary care. I wonder if you might talk a little bit about how you think we might continue to work on changing the culture towards one that supported primary care, perhaps through changes in medical education here at Harvard.
Yeah, maybe I'll take this one first. I guess the more I've thought about it, and now towards the end of 4 years here, I'm less convinced that you build a culture of primary care in the long run by convincing others of the value of the work that you're doing. Instead, I think really the path to building a culture of primary care is really focusing the work that the center and that we as primary care students are doing around the values that inspired our original paths in medicine. And I think we grow respect among peers and colleagues when they recognize the values that we have, the values that they share, and recognize the ways in which our careers in primary care allow us to deliver on those values. So both Megan and I have talked a lot about advocacy, and continuing on that theme, I think the center really has a tremendous network of community health centers across the Boston community that it works with. And when I think about so many other students and colleagues who share this passion for advocacy, recognizing that if we as the center and we as students really focus in on our work to be around what we hear from the communities at those community health centers as their priorities, I think others will recognize the ways in which the center and our work is in primary care is built around that same unifying and universally appealing theme of community advocacy.
Thanks.
So I think I'll add, as I get to, I'm about to graduate, I've been reflecting a lot on this. And for me, Harvard was a really great place to learn about primary care and to find out where I belong within the medical community. But I think overall, Harvard doesn't produce as many primary care physicians as you might expect or as you might want. And this year I was the only student who matched in family medicine, and I think we can do better than that going forward. Of course, we had more students match into internal medicine primary care tracks or pediatrics primary care tracks, but I think we can all agree that Harvard does tend to match more students into subspecialties than it does into primary care. And on a certain level, that's okay, right? Because we need excellent people in those positions, and we need people to find careers that are rewarding for them and that they fit their academic and personal goals. But on a systems level, we know from some of the research that Russ presented earlier that, decades of research before that even, that good quality primary care improves outcomes for patients at lower cost for healthcare systems in ways that decrease disparities within vulnerable communities. So I think we need to do a better job of having a robust primary care pipeline. And one of the ways that we can do that is to work on family medicine at Harvard. So there are about 10 schools, 10 medical schools in the country that don't have a department of family medicine, and Harvard is one of those. The consequence of which is our third-year medical students aren't required to rotate through a family medicine clinic. So a lot of people that graduate have never been in a family medicine clinic. They've never worked with family medicine residents. So it's not really that surprising when a lot of people don't choose to match into family medicine. So I think the first step in sort of transforming that is a Department of Family Medicine. That can happen unless the Harvard hospitals in which we train were to support those departments. And that's a really complex problem for those hospitals. There's multiple reasons why that's hard. But I think that we can and should be doing more to show students the joy and satisfaction available in a primary care career, because that's good for students, but more importantly, I think that's good for the patients that are served by the hospital who need access to primary care in a variety of different settings. And I think a Department of Family Medicine could go a long way to putting a little bit more muscle behind Harvard and our hospital's commitment to primary care and communities in Boston. So.
Thanks very much, and thanks for bringing up the issue of family medicine. As you know, the center has been a major support. We've created a home for family medicine that you both alluded to that connects students and faculty and helps support students for scholarship, for mentorship, for clinical experiences in family medicine. We do need a hospital to work with us to champion creating a family medicine program and residency program, and the center would love to see that happen, and we'll continue to actively work on that. So thanks for bringing that up.
With timing, we get into the 5-year plan.
Okay. Mark's suggesting that we move along, so we have one last question, and then we'll open it to the audience.
Questions coming.
Yeah, so one last question. So what's your next step in primary care? What do you hope to be doing in the first 5 years of your primary care career?
So I'll start this one. I'm headed to start my residency this July at the University of Colorado in Denver. My training is going to be at a federally qualified health center called Lowry Family Health Center. It's a hub for care for refugee populations in Denver and the underserved in Denver, and I'm really excited to start my training there. As we've talked about, I really love advocacy. I love health policy. I love politics. I think that that's going to be on the back burner for a little bit while I train and do my residency. But ultimately, I'd really like to be able to find a way to incorporate that into my clinical career. I really like the legislative side of health policy. So in the future, I hope that I can do some thinking about how to combine that with my clinical interests, probably on a local or state government level.
Well, unlike Megan, my next year is not fully defined, but I am participating in the National Health Service Corps, which supports medical education in exchange for a commitment to return and work in a medically underserved community as a primary care physician. And so following my primary care residency training, I plan to fulfill this commitment. And some of my clinical experiences here at HMS have helped me to sort through what might be the right type of community and setting for me to work in. And so I think that is either my home community back in Central Appalachia or a site through the Indian Health Service. And in terms of what holds beyond those 5 years, I'm not sure, but I do know that the bulk will be spent doing my clinical training and then starting my commitment to serve in one of those communities.
That's great. Before we move to questions, I just want to say that you are the hope for the future. As we think about the revolution in primary care and transforming primary care, it's really people like yourselves who are going to lead that revolution and lead that transformation. And it's a privilege for us here in the center to be able to work with students like yourselves. And I thank you very much for sharing today and for answering questions. I'll now turn to the audience. If there are questions that people have for any one of the three of us, we'd be happy to take those. Dr. Donoff.
So, thank you very much. I'm into revolutions, and I noticed that you have a dual degree. I also noticed that there are many MD, MBA, MD, PhD, MB, MPPP, but no MD, DMD, or DDS programs. If you were at Cambridge, you probably know Brittany Dillon, who's a DO, DMD, who matched to family medicine. What do you do when you have an oral health problem?
Well, fortunately, there is this community within the broader primary care community at HMS that recognizes the importance of integrating both oral health and what we traditionally see as medicine and in the domain of an MD or a DO. And I've gotten to get some support and mentorship from the MGH Rural Health Fellowship Program, of which Lisa Simon is very involved. And so they have actually been putting on some workshops on for their fellows and for other people who are involved in the program to learn some of the important skill sets of oral health so that it can be more integrated in clinical practice as a primary care physician. But I think as the type of settings that both Megan and I are hoping to work in our career really recognize this need for comprehensive access to care. I think that's one of the things I find really exciting about working in a federally qualified health center that can integrate both oral health, behavioral health, and what we traditionally see as medical care in the same building so that we meet the full spectrum of our patients' needs and do so in a team-oriented and team-structured approach.
Okay, thank you, Dr. Donoff. Other questions? Sure. So one of the questions is universal health coverage achievable in low and middle income countries? This came from India, from Facebook. I don't know whether either the students want to take that on. So I would take that. So I would say that it has to be achievable. We in the center believe in health equity. We also believe that health care is a right that everybody should have. And some of the work that we actually do in the center involves also global health. There's a conference going on right now where we're talking about how we build capacity through primary care and how we actually make universal health coverage achievable. Our colleagues in global health and social medicine have a conference that's focused on this topic as well. So there are many people working and thinking about this, and I think it's something that just is going to happen. We actually have to have universal health coverage in our country as well. Other questions?
A bit of history and a question. In 1929, that's 90 years ago, the Council of Medical Education issued a report. William Rapelier edited the report. A. Lawrence Lowell of Harvard, who was the president of Harvard then, was on the commission. And it made several observations. Two of them were, one was the need for increased primary care physicians, 1929, and the second was the need to look at health care for all. We haven't gone very far in 90 years.
I'll take that as a comment. But I agree.
Maybe the persistence through time speaks to the value and importance of addressing both of those things. And I think there's no easy answer, and I think that's why we still are wrestling with those two big themes 90 years later. And I think fortunately right now at HMS, there's a community that's assembling around those two themes. And so whether or not we have these same questions 90 years from now, I hope not, but I think the community that we're building here is better set up to make some progress and move the needle in a positive direction.
Hi, thank you all so much for what you're doing. I'm a huge fan of primary care. I myself am a nephrologist who works with a lot of primary care physicians closely. Megan, you mentioned you're the only one applying or matching to family medicine this year from your class. I went to school at Baylor College of Medicine in Houston, similar story a few years ago. What are some of the concrete steps you see in terms of making family medicine maybe the most popular match, let's say 5 to 10 years from now?
That's quite a tight timeline there. I think the first step, I'm not sure the first step. I think one of the mid-end goals is the Department of Family Medicine. You have to have residents who are going to inspire students, and you have to let students see what family practice is in the community every day in a real clinical setting. And the clerkship has to be on the same level as all the other clerkships we do, so that it's of equal value to all the other aspects of our medical training, right? So I think that ultimately you have to have that. To get there, though, the center has a long history of student activism around this issue and around primary care at Harvard. And we've made, just in 9 years, I think, I've only been here for 5 of those years, but we've made a lot of progress as a student community. The folks who were my mentors when I was a first year were some of the folks who were intimately involved with founding the center, and student activism and student commitment and students showing that there's a demand for this. We came to medicine with this optimism. We came to medicine because we wanted relationships. We came to medicine because we wanted to serve patients and communities. That's a really natural fit for primary care. So, how can we help I think student activism is really, really important. It was 9 years ago, and it still is. We also have a really strong faculty community around family medicine, led by Kathy Miller at the Home for Family Medicine at Harvard, and she wrangles everyone together to provide a lot of mentorship for students who are interested in family medicine right from the beginning. So I think our students and our faculty are pushing, and we just got to keep pushing.
Yeah, and just to echo what Megan was mentioning on the real importance of exposure to residents and attendings as a part of the core clinical training during medical school, I think that really speaks to some of the internal struggle that I had during my core clinical training here at HMS, and that I think gone are the days in which you will encounter an attending or a resident who actively dissuades you from pursuing a path in primary care, like some of the stories that you hear when you talk to older primary care physicians. But I think there's a real power in the subtle recruitment of working alongside residents and attendings who are rightfully inspired by the work that they're doing and see your engagement in the learning and encourage you to follow a similar path. And so I think that is a real big part of why we don't produce a lot of family physicians at HMS, is because you don't have a similar experience playing out for medical students during their core clinical training here. So it's not that we're at the Brigham or at MGH and BI and our attendings are saying, oh, you shouldn't do primary care, like you're too smart for that. I think that doesn't happen, but what does happen is you're just working alongside people who are incredibly talented and applied to meeting the needs of their patients, and that inspires you to follow a similar path. And so that can redirect your passion and your energy if you came in thinking that family medicine may have been the path for you at the start of medical school.
I should say there's a lot of interest in family medicine. One of the outside questions was about that as well, so I won't repeat it, but it was along the same lines. Yes,
Yes, congratulations for all the great work that you're all doing.
thank you.
My comment is the following. So I have the sense that sometimes the world of the primary care physician and the world of the specialist are seen are totally isolated and with no possibility of interaction. But my sense is that there are a lot of specialists who are really interested also in social determinants of health and working with underserved communities. Similarly, I think that there's a lot of primary care physicians who can get so good at managing some difficult problems, et cetera, that I see that there's the possibility of that interaction. So my question is, do you have any examples or experience about closely collaborating with specialty care arenas or specialists that share sort of the same passion and commitment to helping some of the populations that you both are very interested in?
Sure. So I'll give a specific example from my first summer when I did a research summer in Navajo Nation. So in Navajo Nation, there is a really, diabetes is a huge problem, right? And a lot of the nephrologists out there will provide a lot of community outreach materials to help community health workers educate in communities and help prevent some of the complications of diabetes, including the kidney complications. So those specialists are also extremely passionate about reducing health disparities within that community, and so that was a wonderful example. They did a lot of partnering with the health centers and with the primary care doctors and with other members of the primary care team to make sure that that sort of specialty level nephrology gets into primary care and gets into the education that we give our patients and the prevention activities that we do. So I think that was a good example for me of seeing social justice and an eye towards health equity in a specialty setting.
Yeah, and I really appreciate your question because I think it's often too easy to fall into a conflict of us versus them, and I don't think that is productive to improving what we're here to do, which is meeting the needs of individual patients and communities. And answering your question on examples in which the collaboration can be done really well reminds me of some time that I spent in Western Massachusetts in a community health center with one of the center affiliate faculty members, Steve Martin. And I know Megan and some of their community health leaders during last year's Student Leadership Committee organized a visit out to that clinic in Barrie. And what they do there is this really innovative approach using telemedicine through Project Echo to support the primary care physicians in meeting the needs of complex patients. And I think the Project Echo model, which originally started in New Mexico to treat hepatitis C patients in that state, has really expanded as this gold standard for how specialty physicians and primary care physicians can work together to meet the needs of their community in a way that is really towards the shared mission of community needs and achieving health equity.
Okay, thank you. Thanks very much for the question, and thanks for those great responses. We are at the end of the hour. I want to thank everybody for being here. Thank you to Gina for the opportunity, to Gina Vild for the opportunity to do this, and I want to lead a round of applause for our students who did a wonderful job.